Yes, as already kindly introduced, my name is Helga Koivu, and I come from Turku, where I now work in a small private orthopedic hospital, Pohjola Sairaala. My background is in the university hospital, and there I worked also for Rheuma orthopedic unit for 4 years. I have been working as a foot and ankle surgeon for over 15 years now. My presentation here today is a hammer toe correction with the bioabsorbable pin. But besides that, I will also talk about background and diagnosis of hammer toes, as well as some related forefoot pathologies. There are different kind of lesser toe deformities depending on where in what joint the deformity is. The hammer toes and claw toes are the most common, and they are actually treated exactly the same way with the same principles, even though there is a difference in the DIP joint. Mallet toe is usually very painful because there is a callus under the toenail, and the crossover toe is technically very demanding when thinking about the surgery. Even the deformity can be quite small, and in only one small toe, it usually causes a lot of trouble for the patients. Most common complaints are metatarsalgia, and it means pain on the MTP joints, the metatarsal heads. Calluses are very common, and they develop to the places where there is extra pressure or the shoe is rubbing. Shoe fitting problems are also quite common, and patients have problems with gait and posture. And it's especially with elderly people, this can be a big problem. The calluses tells us always where is the pressure. So they are in all foot and ankle problems, they are quite important to surgeon. The hammer toe is usually a progressive deformity. It starts with a mild and flexible deformity and progresses to a more severe and rigid deformity. This is usually quite slow, and it can take years to develop. There are multiple causes causing these kind of deformities, and every time when we examine a patient with a hammer toe, we have to think about the whole foot, because in most cases, the hammer toe is a part of a larger disorder of the foot. In rheumatoid patients, the hammer toes develop because the disease is destroying the MTP joints, and most rheumatoid patients have a disease in the MTP joints early in the course of the disease. Especially in cavus foot, it's very important to also remember the neuromuscular diseases like a Charcot-Marie tooth. And even though there is no neuropathy, the hammer toes are very common in cavus foot. The treatment, however, is different in cavus foot, because in many cases, in those patients, when the hind foot is corrected, also the hammer toes will straighten. So many times you don't have to even address the hammer toes themselves. Trauma can cause hammer toes many ways, and in some cases there is no obvious reason for the hammer toes. And most of those patients tell you that their parents or grandparents had exactly the same toes. So it's in many times also hereditary. This is a quite common hammer toe patient with us foot and ankle surgeons. Here we can see the hallux valgus, which with the hammer toes, and hallux valgus transforms the load from the first ray, first MTP to the second MTP, and this is why the hammer toe develops. The stability of the first ray is important because most of the load should be transferred through the first ray. It's not the definition of an unstable first ray is not very clear because we don't actually know how much motion there should be in the first ray in the normal foot. But when we look foot like this is a hallux valgus patient coming to surgery, and if we see the motion, what is happening, I think it's very clear to say that the first ray is not functioning as it should. And this is how we can test it. This is the same patient in the operating table. And even though we don't know how much motion is normal and what is not, I would say that this is not normal anymore. Some patients might have professions or hobbies that will cause excessive pressure and load to the toes. And there are many ways that trauma can affect also the toes. In some cases of this kind of ankle fractures, and more commonly actually with the fractures of the tibia, the long flexors of the toes can be injured. They are located in the deep posterior compartment of the leg, and they can be injured when there is this kind of trauma. This is a little more rare case of trauma. This is a traumatic amputation of the first ray, and as you can see, the second toe has been carrying all the load and is now in a very rigid claw position. And sometimes even so little trauma as a fracture of the toe can also cause hammer toe if it's malunited or if it's intra-articular. When we look at the hammer toe, we always have to think about the congruency and motion of all the joints involved, the MTP, the PIP, and the DIP, and also the function of the flexor and extensor tendons, muscles and tendons. Because whatever the background is for the hammer toe, it is always a matter of tendon balance. The tendons or muscles affecting the toes can be divided in extrinsic and intrinsic muscles. The intrinsic muscles are those muscles that are located in the foot. So there is a lot of muscles, mostly short flexors and extensors, lumbricalis, interossei, and so on. And the extrinsic muscles are the muscles that are located outside the foot. And those which straightly affect to the toes are, of course, the long flexors and extensors of the toes. And the normal alignment of the toe, it requires a stable tendon balance between these extrinsic and intrinsic muscles. And it's a very delicate system. And if there is a disorder in this balance, it always leads to deformity. Besides the tendons and the tendon balance, the bony alignment is also important. The differences between the length of different metatarsals is usually referred to as metatarsal parabola, because the line between the metatarsal head, it should be in a shape of a parabola. And if this is disturbed, it always leads to problems. And it many times the toes looks like this. In some cases, it can be even congenital, like with this young lady here who has a bony anomaly, congenitally short third and fourth metatarsals. But I think most usually it is because of the surgery that has been done before. And here are some examples. Here is a patient who had Freiberg's disease, which is a avascular necrosis and secondary arthritis of the second MTP, the second metatarsal head. And somebody has corrected it with a metatarsal head resection. Only one metatarsal can never be shortened or resected. It always leads to problems. Besides the floating toe of the second ray, the second toe, there is also deformity of all the other toes. This patient was corrected by correcting the alignment of the first ray and shortening the other metatarsals so that the parabola was better. Some surgeon has had an even better idea to treat the Freiberg's with the MTP2 fusion. This also should never be done. This is the only one I have seen. Unfortunately, it was also fused. And this causes a lot of pressure under the second metatarsal head. And this patient also had very painful situation. And it was treated by resecting the fusion. This is the most common thing you can see after not so successful surgery. This patient had quite mild hallux valgus and second and third hammertoes. The PIPs were rigid. This was operated. You can see there is a lot going on postoperatively, but mainly the patient still has hallux valgus, and the second and third toes are still rigid hammer toes because they were not addressed. Instead, they were tried to fix by shortening of the second and third metatarsal with a Wales osteotomy. And of course, you can say a lot of the hallux valgus correction, but if you look at the metatarsal parabola, it's disturbed, and now there is also pressure under the fourth metatarsal head. Sometimes the situation can be also so that the toe is missing. This leads to the same kind of situation as too much shortening or resecting the metatarsal head. And this was treated by stabilizing the first ray by MTP fusion and shortening the other metatarsals so that the parabola was somehow restored. Now someone might think that where is the toe? It was missing for a quite good reason. It was borrowed by a hand surgeon for the patient's right dominant hand, which had a trauma. All the other fingers were amputated, and this toe was used for the little finger so that it enabled some kind of pinching. Okay, let's go to the treatment a little more detail. Most of the hammer toe patients can cope with non-operative treatment with spacer shoes and different kind of padding, orthotics, and taping. But of course, operative treatment is indicated when there's no relief from the non-surgical treatment. If there is a very painful deformity, the deformity is progressive, there will be serious skin problems like ulcers on the PIP joint, or there is some serious shoe fitting problems. Of course, this is never cosmetic surgery. The aims of surgery is pain relief, resolvent of skin problems, and for especially in the elderly people, improvement of gait and posture. Generally, with this, after this surgery, pain relief and patient satisfaction is usually high, and there are no differences between older and younger patients. So if the older patient has a hammertoe which is making walking very, very difficult, and the patient is fit for surgery. Otherwise, it's very, very good to treat this so that they can be ambulatory and live independent life. Patient information before surgery is always important. Toes are very peripheral, and the skin on the dorsal side of the foot has a higher risk of skin healing problems. So these are things that has to be informed to the patient. And if the PIP joint is operated, it will be rigid, and this does not cause any harm to the patient, but the patient has to be informed. Otherwise, they are surprised why the joint is not moving. Before surgery, you have to plan the extension of the procedure, and because in those cases, especially where you have to operate many toes, the skin incisions has to be planned very carefully. We have bone procedures and we have soft tissue procedures, and it is always a combination of both. The PIP fusion or trochlear resection and the distal osteotomy of the metatarsals are very, very common, and I always also use the FDL transfer, and these are the procedures I will show you. Also the elongation of the extensors and the dorsal release of the MTP capsule is very often needed. When I started my career as a junior doctor, I remember that some orthopedic surgeons were still doing this, but I would advise not to do any base resections for the toes. They will result this kind of short and floating toes, and they are very, very difficult to correct. Some words about the veil osteotomy. It's indicated only when the MTP joint is not reduced with other means. And as I showed you before, it's if you have to shorten a lot, then you have to shorten the other ones too, because of the parabola. So do not shorten one MT too much. And besides shortening, it is very important if we do a distal metatarsal osteotomy that we don't disturb the center of rotation. Otherwise, because of the intrinsic muscles, the toe will be unstable. As I said, I almost always use the FDL transfer. It is very, very easy to do, and biomechanically is very important. The FDL, its insertion to the distal phalanx is transferred to the proximal phalanx, so that the flexion will be transferred. The power of the flexor will be transferred to the whole toe instead of just the distal part of the toe. When opening the PIP joint for fusion or trochlear resection, it is easy to take the tendon right here, so that you don't have to do any plantar openings. If the PIP joint is not opened, if you do only an FDL transfer, like in the mobile hammertoes is possible, then you can use plantar approach. But there is enough space in here to take it also here. So the capsule is plantar capsule is opened of the PIP joint. The tendon is grabbed and cut as distal as possible, and then it is cut in two halves. and they are either sutured, or some surgeons like to use some anchors to the proximal phalanx. And here you can probably see that the fixation of the PIP joint is done with the absorbable pin. This is the most, I think, traditional procedure for the hammer toe correction, the trochlear resection. The trochlea is just resected, and it's fixed, for example, with the K-wire. What we, however, think is that the PIP fusion is more stable, and there will be less pain and less swelling, and the tendon function is in better balance than with the trochlear resection. However, there is at least one study, a randomized prospective study, where they compared the PIP fusion and PIP resection fixated with the K-wire and found no differences. This can also be related to the fixation method, as K-wire fixation is not without problems. Of course, the K-wires are cheap and they are available almost everywhere, but they are not so stable. They do not have any compression, or they don't provide rotational stability. There is, of course, an infection risk. They will move, and actually the patients don't like them too much. They are quite afraid to move with those K-wires, and they complain, for example, that when they sleep they can get stuck to the sheets and so on. Because they are not so stable, they can cause more swelling, more pain, and also risk for rotational deformity. If, however, the K-wires are used, they are many times they are fixed also over the MTP joint. And if that is done, it's very important to get the alignment and stability of the toe before the fixation, because if the toe is fixed to the metatarsal and otherwise is unstable, it will be unstable when the K-wire is taken away. Because of the problems of the K-wires, there are now several implants that can be used for internal fixation. Most of them are metal. There are also some poly implants, and at least one bone matrix allograft that has been used for this indication. Absorbable pins are I think, very widely used, but there are no studies so far regarding the use of those in the hammer toes. This is a quite recent systematic review, which had 5 studies comparing K-wire with internal fixation, and quite a lot of patients and toes were involved. And the implants were SmartToe, Nextra, Canulink, and Tenfuse. So mostly these metal implants, and one poly and one allograft. And the results were that there were no differences between pain or patient satisfaction or foot function, but complication rates were higher with the K-wire, and union rate was significantly higher with the internal fixation. So for those reasons, they seem to be better. However, they are also they cost a lot, and a few years ago it was published this kind of cost effectiveness analysis, where they analyzed the long-term cost and quality adjusted life years, and they say that implants were more effective minimally, but they still carried a significantly higher costs. So their conclusion was that you could get a real benefit from the implants if they cost at maximum $300 US. I have used a lot of Kirschner wires. Of course, when I was in the Reuma orthopedic unit, we only used the K wires because there were some problems and the patients didn't like them too much. I have switched to internal fixation. Once I have tried a metal implant, I didn't like it, and I think it costs too much. And I think now for over 5 years, I have used an absorbable pin, and in the recent years, this Inion Freedom pin, because I have been quite happy with it. And here are some photos how it is done. Here is the trochlea is resected, and as I always want to do a fusion of the PIP joint, the chondral side of the middle phalanx is resected, and you can see the FDL parts there waiting to be sutured. First, I will drill for the both bones, and also measure the right measure for the pin. Then the pin is cut to the right measure. We have only the 50 millimeter pins, so that it's usually from 25 to 30 millimeters length what we need. Then it will be inserted in the proximal phalanx and then to the middle phalanx. And this is usually very stable and very easy to fix like this. And I also like to bend the pin a little bit so that the PIP will be in little flexion. Here are some patient cases. This is the one I showed you before with the traumatic amputation of the first ray. After surgery, it looked like this, and here you can see the X-rays, how it looked before the operation and after the operation. And this is the more usual patient case. This is the lady which was shown on the video in the beginning, hallux valgus and a hammer toe. And here is how it looks when it's fixed. I almost always, with that kind of hallux valgus and unstable first ray, I do a Lapidus procedure. And as you can see, that you can't really see even the drill hole of the absorbable pin. And we are now planning to start a study, because there are no studies of the absorbable pins and hammer toes. And we are going to study all the patients operated for hammer toe with PIP fusion using an Inion Freedom pin. Patients included will be those who have at least 12 months after the operation. They will come to one visit, and we will take a foot X-ray and also clinical examination, some scores that are used, and of course we see if they have pain and would they come to the surgery again, union, alignment, joint congruency, complications, and so on. We are ready to start. We are just waiting for the approval of local ethics committee. The other indication where I usually use also these absorbable pins, you can use them, of course, in many indications, but my favorite is the fibers, because as shown before, you cannot do a resection of the metatarsal head or fusion. This closing wedge osteotomy of the first of the metatarsal, distal metatarsal, is very good. It works very good, and I always fix this with the absorbable pins, because you can do it from the joint, from the chondral side. What you could now remember for this presentation is that when you see a hammer toe, don't look only the hammer toe, think about the entire foot and try to figure out why there is a hammer toe. MTP joint balance is very important, and if the distal MT osteotomy is needed, then the metatarsal parabola should not be disturbed. So do not shorten any single metatarsals. Any kind of deconstructive surgery, meaning resection of the metatarsal head, should be done only to patients with destroyed joints, and they are usually rheumatoid patients. And for those patients also, no single metatarsal head is resected. It's always done so that everyone is resected, and the metatarsal parabola is still there. And some very important things to remember are tendon balance, and again, tendon balance. Thank you.
Yeah, thank you for the presentation, Dr. Koivu. So it was very interesting and really thorough presentation about the foot anatomy and surgeries and diseases. So I learned a lot from that. There was no questions from the audience, but I would have one question about the how did you decide to start using the Inion or resorbable pins in early days? So you did use the metal implants, and then you switched to bioresorbable implants. What was the reason at that time?
The reason was just to get rid of the K-wires and get some internal fixation. And I don't actually remember why it was the absorbable pin. I think one company had one kind of pin which was actually, at least they were marketing it as for exactly the hammer toe surgery. I didn't like it too much, but I don't actually remember why these pins then were chosen. Yeah. I think there was probably a good salesman or that. Yeah. But I had a similar pin from another company for some time, but I think it was technically not so easy to use. And then I tried this Inion pin, and it has functioned well. So that's why I have continued. The metal implant, I once tried the Smart Toe. I think it was not so simple to use. It was kind of complicated to use. And of course, the price, it's very high. And the one patient, of course, it's only one. But the one patient, she had it was very painful, the toe, for a long time. I don't know if it's the implant or something else, but I wasn't satisfied. So that's why I have continued with the absorbable pin.
Yeah. So one thing came in my mind also, that you mentioned about that the K-wires, they are round, and then they do not provide that much rotational stability. Yeah. So yeah. With the Inion Freedom pin, we have a hexagonal shape. Do you feel that stability when using the hexagonal design?
Yes. I think it stabilizes very, very nicely on the operating table, but at the same time, it's not too hard to put in the drill hole, because it's also important that you can put it there. It's not too tight, but it stabilizes very nicely, and I haven't seen any rotational problems with these patients.